welcome back. We will now address the third part of urinary incontinence, and we will focus now on examination and investigations. The last video will discuss various management options. Okay, before you start viewing my video, would you mind asking yourself, how would you specifically like to examine the patient who presents with urinary incontinence? And what are you specifically looking for or feeling for? Vaginal examination. Inspection of the vagina, you might want to answer the question, is there atrophy visible? Thinning of the vaginal epithelium. The epithelium is sometimes more pale, and there's loss of rugae, the typical plications of the well-estrogenized vagina. Are there signs, visible signs of pelvic organ prolapse or uterovaginal prolapse? Interesting, quite often there is no urinary incontinence with anatomical variations. And paradoxically, when there is a large cystoscale, which we'll discuss already in the videos about uterovaginal prolapse, one of the presenting symptoms might be urinary retention. Of course, when we examine a lady, we will ask her to cough, and sometimes we can confirm leakage of urine. When that's present, that's okay. When it's not present, that doesn't change my management a lot because her history is guiding. Okay, are the pelvic masses to be found? Very rarely a pelvic mass might result in urinary incontinence, but usually it's the other way around. A pelvic mass will be associated with retention. And then, is there discharge from the urethra or is there tenderness? Discharge could point at infections, STI, sexually transmitted infections, or tenderness pointing at maybe bladder infection. Can we see leakage from a fistula, or is there a developmental abnormality? Very rarely so. Good. Usually, gynecologists and GPs, when you do a pap smear, will examine women in the recumbent position. So I would think stick to that because you're used to the anatomy in that typical position. Can you see visual? Can you see urine loss? You will ask her kindly to cough, and sometimes you could ask her to bear down with a full bladder. Typically for STES, urinary incontinence would be that you can see urine escaping from the urethra straight away. A neurological examination, a detailed neurological examination, is part of the assessment of a lady who presents with urinary incontinence. So check the sensation of the various branches of the pudendal nerve, check anal reflexes and pudendal nerve function, but that's outside the scope of my video. Okay, so the examination might not demonstrate variations in the anatomy, and that's perfectly all right. Investigations. Investigations, yes, we always would include a midstream urine for microscopy and sensitivity to find out whether there is a urinary tract infection which could contribute to, for instance, urge incontinence. Urine cytology only if there is de novo urge incontinence in the elderly, because it could point at a tumor, especially in the bladder. Imaging is not routinely recommended. Only an ultrasound scan if the pelvic exam would be completely inadequate. In some research centers they would do ultrasound special imaging or specially contrast fluid, but that's not part of the routine practices yet. Another investigation we might have heard of is urodynamic testing or urodynamic investigation. So in conclusion, the history is number one. Testing. When we test the so-called urodynamic testing, here you see a setup in where there is a chair. We see the chair here. The woman will be with her legs in the stirrups. We have here a monitor which can measure the pressure via two different transducers. There is here an ultrasound scan, and this is part of the equipment in the room where we do urodynamic testing. I would like to explain the principles of urodynamic testing briefly without going overboard. So here we see a diagram of the anatomy. The bladder, the urethra, behind it the vagina and the uterus, and behind that the bowel and the rectum and the anus. When we do urodynamic testing, usually a transducer is inserted inside the bladder together with an indwelling catheter. So this will measure the build-up or the changes in intravesical pressure. And secondly, there's another pressure testing device which is either inserted, as here is depicted, in the vagina, and sometimes it's inserted in the rectum. This pressure probe represents the intra-abdominal pressure. Good. So this is the setup diagram. Now let's go for the urodynamic testing of the function of the bladder and the urethra. There are three stages when there is a sensor in the rectum or in the vagina, and as we've shown in the previous picture, inside the bladder. First, we ask the patient to empty her bladder, to void, to do number one. If the bladder, then we can check with an ultrasound scan whether the bladder is completely empty or if we are dealing with urinary retention, bladder retention, we can measure the volume. Second stage, we now fill the bladder retrograde with warm body temperature, normal saline, and we very slowly fill up the bladder. The pressure device inside the bladder will check whether the detrusor is contracting whilst the bladder is filled up. The detrusor muscle should not show any signs of contractions in a normal situation. If yes, so if there are frequent contractions visible on the pressure system inside the bladder, it confirms urge. Then we continue to fill. A little lady indicates, well, first you indicate when she feels filling, when she is aware of the filling, but also we will fill the bladder till maximum capacity. In other words, the patient says, stop, stop, I'm bursting. We can measure at what volume this phenomenon takes place. So the maximum filling capacity. Thirdly, now we will empty the bladder, and that's the voiding stage, where in the meantime, whilst the bladder is being emptied, we gently retract the pressure catheter in the urethra, through the urethra, and so that means during that voiding phase we can measure various pressures inside the bladder and inside the urethra. Those are the principles of urodynamic testing. I do not want to go into detail because that's more appropriate for a registrar or a subspecialist training. That's not required for students in the general training program. So interesting, whilst urodynamic testing is done quite a lot in daily practice, it's not routinely recommended. I remember attending a conference once where a person made a lovely statement: urodynamic testing was regarded as the poor cousin of a good history. And that tends to be very correct, that statement. So whilst it's regarded, urodynamic testing, by some as the gold standard, we have to realize it's an invasive testing method. It's quite embarrassing for a lady who is at the receiving end. It's expensive. It requires special equipment and training. And interesting, whilst urodynamic testing is done quite a lot in practices around Australia and New Zealand, there is no solid evidence, at least I have not found a randomized clinical trial, to tell us that urodynamic testing results eventually in better outcomes, less urinary incontinence in the future, etc. Okay, interesting that we see there's a slight discrepancy between practice and evidence or knowledge. So in conclusion, as far as investigations is concerned, routine microscopy culture and sensitivity is done, and there's general agreement, and other tests only if need be. So only an ultrasound scan, or only cytology of the urine, or only urodynamic testing if the history is not clear, or if a lady had previous operations. Of course, then we need to be extra meticulous. So it's very easy. The history is number one. The examination, you should not worry if the examination doesn't show any abnormalities. I show you here a picture of a movie from quite a while ago, Easy Rider, with Jack Nicholson. Beautiful movie about feeling free. Anyway, this concludes the video number 3, examination and investigations as part of urinary incontinence. Thank you.